afternoon. My name is Karen Sampson, and I'd like to welcome you to today's Ask the Expert webcast, Behavioral Management and Combined Treatment for Children with ADHD. Today we welcome William E. Pelham, Jr., Ph.D. of the Center for Children and Families at Florida International University. He is the founder of the Summer Treatment Program for Children with ADHD and was one of the leading researchers on the Multimodal treatment study of children with Attention Deficit Hyperactivity Disorder. The Ask the Expert webcast series is presented by the National Resource Center on ADHD, which gives the general public access to top clinicians, researchers, and other professionals. The National Resource Center is a partnership between CHADD and the Centers for Disease Control and Prevention and serves as the national clearinghouse for the largest evidence-based information on ADHD. A recording of today's broadcast will be available on the National Resource Center on ADHD's website, Help for ADHD, in about 2 days. To view the recording sooner, please follow the same link you used today to join us. Join us to view the recording. The recording will be available about 30 minutes following our presentation. We may not be able to get to all of your questions today. If you would like to talk with a health information specialist for further information on today's topic, please contact us Monday through Friday from 1 to 5 p.m. at 1-800-233-4050 or online at www.helpforadhd.org. Finally, following today's webinar, a brief survey will appear on the screen. Please take a couple of minutes to let us know what you think and how we can better serve the ADHD community through the Ask the Expert webcast series. It is a privilege to introduce today's guest expert, Dr. William Pelham. Dr. Pelham is the director of Florida International University's Center for Children and Families. He has authored or co-authored more than 300 professional papers dealing with ADHD, including the Multimodal treatment study of children with Attention Deficit Hyperactivity Disorder, which looked at the relationship between behavioral management and medication management for ADHD. In 1980, Dr. Pelham began the Summer Treatment Program at the New York State University at Buffalo. It is an evidence-based program focusing on behavioral management for children. For those of you who would like to ask Dr. Pelham a question following his presentation, written questions can be submitted in the questions box on your GoToWebcast toolbar as indicated by the red arrow shown in this slide. All questions are moderated, and we will get to as many as we can during the Q&A portion of the webinar. Again, we are very pleased to welcome today's guest expert, Dr. Pelham. Dr. Pelham, if you would like to begin.
Thank you very much for the introduction, Karen. I want to start with, can you hear me?
We
Hello?
can hear you. Please go ahead. Hi.
Start with it.
Please go ahead.
Yep. I want to start with a slide that shows my disclosures. I will be talking today about medication as well as behavior management because we're talking about behavior management and combined treatments. And I've actually had a lot of experience working with pharmaceutical companies. Our group did the very first study on Concerta for the manufacturer. We did the first couple of studies on Adderall with Shire and have been a part of lots of the multi-site studies looking at the new generation of medications for ADHD. So I say this because I'm very conservative about using medication versus psychosocial treatments, and that comes from experience, not from a blind allegiance to psychosocial treatments. I have probably 400 publications, probably about a third of them on behavioral treatments, about a third on medication, and about a third on the combination of the two. So I wanted to show this slide to let you know that I have had lots of relationships with pharmaceutical companies, and in our interventions, lots of the projects that we do involve using medication with ADHD kids. As you'll hear, my preference is to start with psychosocial treatments and only use medication if necessary and use low doses. But I wanted to start with this disclosure slide to emphasize that I do have knowledge of medication. So let me start. I'm going to start with several slides that are designed to convince the audience or to inform the audience about why it's important to do psychosocial treatment for ADHD. That is behavior management, whether you're doing it by itself or along with medication. First of all, I want to note that for ADHD diagnosis, the core symptoms of ADHD have been the same for the past 50 years. The names of the diagnosis have changed. So in the 1950s, it would be called hyperkinetic impulse disorder. In the 1960s, hyperactivity or hyperkinesis. When DSM-3 was published, which was the big initial revision of the DSM in 1980, the term was changed to ADHD, attention deficit, well, actually it was ADD, attention deficit disorder, and then later changed to ADHD, attention deficit hyperactivity disorder. No matter what the diagnosis, the core symptoms have always been inattention, impulsivity, and hyperactivity. DSM-5 remains the same as DSM-4 for all practical purposes, and so anyone who's worked with ADHD has a good sense of what the DSM diagnosis looks like. What I want to emphasize quickly is that diagnosis, the DSM diagnosis, is the least important thing that one does for a child with ADHD. Far more important than a diagnosis is functional impairment in children with ADHD, or problems in daily life functioning. And these are the areas, the slide that I put up show the areas that everyone knows are the common problems that ADHD kids exhibit on a daily basis. Relationships with parents, teachers, and adults, with peers and siblings, academic problems at school, behavior problems at school, and family functioning at home is a big one, and even leisure activities. All those are domains in which ADHD kids have problems in daily life. And it's these problems in daily life, functional impairment, not DSM symptoms, that are the most important things to pay attention to in ADHD. Why? Because it's why kids get referred for treatment. Kids don't get referred because mothers are sitting up in bed at night reading the DSM. Kids get referred because they're having problems in daily life functioning. They're getting into trouble with other kids in the neighborhood. They're getting into trouble with their teacher at school. They're not doing what their parents ask them to do at home. It's problems in daily life functioning is why children get referred for treatment. We've known for 40 years it's problems in these domains that mediate long-term outcome for children. So if you have problems in peer relationships, in parenting, and in academic achievement, you're going to have problems as an adult. Whether you have inattention, hyperactivity, and impulsivity is almost irrelevant. If you don't have these other functional deficits, you're not going to have any problems. So the key thing to focus on in treatment and monitor in treatment, and the key things to change, are impairment in daily life functioning. And our goal is to normalize or minimize impairment, to make children have better peer relationships, for example, to teach parents better parenting skills, and to teach teachers better ways of managing the children in the classroom, and maximizing adaptive skills, teaching social skills to children, for example. And our goal is not elimination of the DSM symptoms. So that's why I say that a DSM diagnosis is the least important thing to think about or to worry about for a parent or a professional working with children with ADHD. It's functional impairment or problems in daily life functioning. So why is it important to treat ADHD in childhood? Well, because they have these problems, peer relationship problems, academic achievement problems, and behavioral problems at school, and their parents have difficulty with parenting. These are the three key domains that predict negative long-term outcomes. We know those are characteristic of ADHD children. We know that the majority of ADHD children continue to have problems as they grow older into adolescence and adulthood, and that emphasizes why we need to treat ADHD in childhood. What's the prognosis for kids with ADHD? I think you can look at the literature for ADHD over the last 50 years and say about a third of ADHD kids have a tolerable outcome. Some have mild problems. A lot of them have to constantly work to adapt to their difficulties. About a third continue to have the same kinds of problems they had as children, but they're now exhibiting them as adolescents or young adults, and those are causing them mild to moderate problems in their daily life functioning. And then about a third have pretty bad outcomes. They can have lots of criminal activity, they can have lots of substance use and drug use, terrible problems getting along with other people, keeping a job, and so forth. So it's to avoid these long-term really bad outcomes that we emphasize so much treatment of ADHD in childhood. In addition, ADHD turns out to be a very costly public health problem. So if you look at the cost of major public health problems in America, everybody knows major depressive disorder is a big public health problem, and that stroke is a big public health problem, and ADHD in children costs about the same as depression in adults and stroke across the lifespan. Alcohol abuse and drug dependence is one of the costliest areas of dysfunction and public health problems in America, and ADHD kids, as they grow older, actually contribute substantially to the cost of alcohol and substance use. So ADHD is a huge public health problem, not just a problem for the individual and for the family. So what's effective treatment for ADHD? I have 12 things listed on this slide, 12 types of intervention, and these are all interventions that are common, but they're not evidence-based, meaning that there's no scientific evidence supporting any of these interventions. Traditional one-to-one therapy or counseling is still, unfortunately, the most common intervention most ADHD children get, or play therapy or cognitive therapy, and there's no evidence that this works. A parent could take their child to a traditional therapist who's doing talk therapy every week for 10 years, and that child's not going to be any better than they were before they started. A lot of people still try diets in ADHD. For years, people talked about eliminating red dye in diets, that would cure ADHD, and it doesn't. There's good studies on that, and it doesn't work. For 30 years, people have talked about biofeedback or neurotherapy or attention training. Now there's a resurgence of interest in that. It's been tried before, twice before, during the 70s and again during the 80s, and it didn't work then. It's not likely to do much now. People have tried allergy treatments, chiropractors try to treat ADHD. All the things that are listed in this slide are the ways people have tried to treat ADHD, but none of them have any evidence base. The last one is a joke. It says duct tape. That's to remind me to mention the teacher in Missouri that got arrested 4 or 5 years ago for using duct tape to tape an ADHD child to his chair so he didn't run around the classroom. That was a terrible decision on that teacher's part, and it didn't cure the child of his ADHD. It was a bad intervention. So these are things that don't work for ADHD, but they are commonly used. Here's what the scientific evidence base says works for ADHD. Behavior modification or behavior management is the main psychosocial treatment to treat ADHD. By psychosocial, I mean not pharmacological, psychological and social intervention. Medication with a central nervous system stimulant is the most common pharmacological approach to treating ADHD. There are hundreds of studies of each of those approaches, and a lot fewer studies, even though the combination of those two approaches is what many experts recommend. And there are pretty big effects for any of these three treatments when you work with ADHD children in the short term. And the key here is short term. These are treatments that we know work in the short run. It's a different question if we look at long-term outcomes. One of the interesting aspects of treatment for ADHD is we know that behavioral treatments work, behavior management works, we know that medication works. A logical question for a parent should be, if both these treatments work, which one should I try first? And that's probably a question that many parents go to their physician with or talk to their child's teacher about at school. Is there any evidence that tells me which one I should start with? And I'll be talking some about some evidence about that later in the presentation. The guidelines on which one to start with differ depending on the professional you ask. If you ask a psychologist, the task force of the American Psychological Association says do behavior management first. If you ask a psychiatrist, the guidelines of the ACAP, the association to which all child psychiatrists belong, say medication first. If you look around the world, in Japan and Great Britain, they say psychosocial or behavioral first, medication not until later. CHAD typically advises people to do both simultaneously. The American Academy of Pediatrics, with their latest guidelines, say behavioral treatment always first for young children, either one for elementary age kids and both for adolescents. Even though behavioral treatments are recommended strongly as treatments for ADHD by most professional associations, including the American Academy of Pediatrics, the largest group of people who treat ADHD children. This slide shows how much the increase has been over the last 20 years in the use of medication to treat ADHD. And the main point to keep in mind here is that the bars on that graph are going up considerably. The 2003 number is 5 times higher than the 1993 number. And I have another slide. I don't know if it's going to be here. No, it's not. Except I have another slide that I could show you that just shows for the last 10 years it's continued to increase. So we have 2 treatments that work, but one of them is being used a lot more than others, and that's medication. In my opinion, the components of effective and comprehensive treatment for ADHD are those that focus on the areas of impairment we talked about earlier. So it's behavioral parent training, teaching parents parenting skills that will improve the way they interact and function with their child at home, and that will help the child to learn adaptive skills and to behave more appropriately. The same thing for school intervention, teaching teachers the same skills that one teaches parents, and then working with the children to teach social skills. And medication should be reserved as an adjunctive treatment that one tries after psychosocial treatments have been started, and you see how far you can get with psychosocial treatments. Why is it important to include parent training? First, no one is taught to be a parent. I'm sure there are many people in the audience who are parents, and if you are like me, you had your first kids and no one told you what to do. No one taught you how to be a parent. You might have been given a book by your pediatrician, or you might have gone to Barnes & Noble and tried to buy a book about how to be a parent. That's one of our big problems in America, is we don't teach people how to do the single most important thing we do as people: raise other kids, raise our kids, raise other people. So you need to teach parents how to be better parents, especially if they're parents of ADHD children, because parents of ADHD children have significant distress of their own, often their own mental health problems, and don't have effective parenting skills, in part because they've tried lots of things with their children that haven't worked. So we have to teach parents how to be better parents. ADHD kids have severe problems in school. Most teachers have not been trained how to work with them, so we need to work with teachers. And as I said earlier, they have severe peer relationship problems. This cartoon is a little joke. It just shows a mother who had 5 ADHD children, and it shows how much stress the children cause for her. She's trying to get some Prozac for herself from her pharmacist. So what does it mean when we say do parent training for parents of ADHD children? I don't know how many people in the audience have ever gone to a parent training class. If you're all parents of ADHD children, I hope that you've gone to get some good behavioral parent training. Most of the best parent training, I think, is done in group settings so that parents can learn from each other. They learn a set of skills that teach them how to get their child to behave better at home. Timeout, for example, how to use timeout instead of spanking for inappropriate behavior. Praise, how to praise their children when they're doing things that they like them to do. That has a terrifically beneficial effect on the kids and on the family relationship. So teaching appropriate, not inappropriate, but appropriate ways of minimizing problems like timeout, and then teaching a lot of positive approaches for parents to use to work with their children. And the way it works in parent training is you typically have a session once a week, and a technique or an intervention or an approach is presented each week, talked about, and then parents are given the assignment to go home and try it and see how it works with their child, and then come back the next week and problem solve. The evidence-based programs last 8 to 12 weeks, and at the end of that time, a lot of people find that they're much better off than they were before, and they've been able to effect big changes in their child's functioning in the home setting. One of the important things to keep in mind is that you can't just do parent training for 8 weeks. We're teaching parents skills in parent training, but for those skills, for the parent to learn those skills and then implement them with the child takes a while, and then once they start doing that, the child has to learn. So parent training is not a short-term, parenting interventions and parenting are not a short-term fix. It's changing the way you parent and then continuing that for a long period of time. And you have to worry about issues like parents who get it, who start doing it, and then over a 3 or 4 month period do a little backsliding. So how do we get people back on track, for example? It also turns out to be the case that As children go through developmental transitions, the nature of what parents need to do with them changes. So when you move into adolescence, you have two problems. You have ADHD, and now you have adolescence. So it's a double challenge for parents to learn appropriate skills that they can use with their children, but appropriate skills exist, and there's lots of evidence about what works and what doesn't. And the good thing about parent training is it's not rocket science. You can offer it in mental health clinics, pediatricians can offer it, lots of schools offer parenting programs for parents, churches, community centers. Parent training is something that can be done everywhere in the country, and it's pretty inexpensive. So what about school interventions? School interventions means having therapists or school staff teach teachers how to implement better classroom management practices in their classrooms that will help children with ADHD. I want to talk just about one technique here, and that's called a daily report card. Every ADHD child in America should be getting a daily report card from his child's teacher. Every single child. It's not hard to do. It's an expectation that every parent should have of every teacher. And there are lots of studies showing that if it's done properly and done consistently, that it will produce big changes in children's functioning. This is what a daily report card looks like. It's nothing more than a report card of the child's behavior and academic work over the course of the day. And the way it's established is a parent works with a teacher to come up with the goals that the child needs based on the teacher's expectations of the child in the classroom and the problems that he's showing. And then the teacher evaluates periodically throughout the day how often the child is following the rules, how often the child is completing his assignments, whether he's accurate, and so forth, and circles a yes or no on the sheet and gives the child feedback at the end of the day. The teacher counts up yeses and nos and sends the report home to the parents, and the parents provide a reward or a consequence at home for having a good day. This is a very simple procedure. It costs nothing but the piece of paper, the cost of the piece of paper that goes home to the parents every day from the teacher, and it is tremendously effective. There are dozens and dozens of studies showing that daily report cards are effective. They're not always sufficient, so sometimes you have to do a daily report card and lots of other things, but every ADHD child should have one. You can go to our website. I'll show you the website at the end of the presentation at FIU and get a daily report card packet that you can download and print and then take to your child's teacher and work with them to set up a daily report card at school. So that's the single most important thing one can do in the school setting for a child with ADHD. What about child interventions? What about teaching better social skills to kids? Unfortunately, teaching social skills is not easy. Getting a child to change their peer relationships is not easy. Some people have tried to do it by having children attend social skills training groups in clinic settings. So you go to a clinic once a week and you talk to a therapist, or you are in a room with 2 or 3 other kids and you practice appropriate social skills. That doesn't seem to work. The most effective treatments, the only things that do seem to work, are more intensive programs that are variations of summer camps, for example, or that are implemented in school settings with a lot more intensity than a once-a-week setting. The beneficial effects of behavioral treatments are huge. Improved functioning at home, at school, and in peer settings. Evidence of benefit from kids all the way from age 4 to 15. A couple fewer studies for young kids, and for older kids, lots of studies for elementary kids, but all the studies show big benefit for children and parents who participate in behavioral treatments. The next to last point here I wanted to make, parents probably don't know what comorbidity means unless they're seeing a psychiatrist for their child. Comorbidity means you have other diagnoses in addition to ADHD. For example, lots of ADHD kids have oppositional disorder or Asperger's, for example. The benefits of behavioral treatment cut across all concurrent diagnoses. So you don't not do behavioral treatment because the child has ADHD and Asperger's. You do more behavioral treatment because you have more target behaviors to work on. And finally, if there's room for improvement after you have done a lot of behavioral treatments, then you move to medication. I wanted to make just a couple of points about medication. We believe it should be done after you do behavioral treatments, and the timing depends on the severity and responsiveness to the treatments. You try methylphenidate and amphetamine-based compounds, methylphenidate, for example, being Concerta, amphetamine-based being Vyvanse or Adderall. You typically don't get much benefit when you move outside of those classes of drugs, or when you start combining drugs together. There's a big article in the New York Times on Saturday about adding Risperdal to a child's treatment regimen. I think that's a terrible thing to do for a child. That's a very dangerous drug with lots of side effects. And if you're going to medicate a child with ADHD and it's insufficient, then you should be adding psychosocial treatments, not trying to add multiple drugs into the treatment for the child. There's no evidence that multiple drug regimens are effective for children with ADHD. Another point on this slide says use at minimal rather than maximal effective dose. The major point with medication is you try to use the lowest possible dose that gives you big gain. You don't try to use the highest possible dose. The highest possible dose has side effects. You want to stick with low doses. And if you're going to use medication and rely on it, you're going to need to do it for years, not for a couple of months. That's another reason to use low doses, because higher doses are going to have more side effects over longer periods of time. The final point here is that we have no evidence that taking medication for a long time is going to improve a child's long-term outcome. So I showed you the long-term adulthood outcomes of ADHD children in an earlier slide. You can medicate a child for 10 years, and there's no evidence that he's going to be any better. That's why it's so important to focus on the psychosocial components of treatment. And this just lists some of the limitations of medication. I already mentioned that, several of those. And a couple of them, additional ones, are that parents are often not satisfied with medication alone as a treatment, and it removes their incentive to work on other treatments. I'll mention that again later. And we don't have much information at all about long-term safety. So we know 10 years worth of medication does not help outcomes, and it might make things worse. We just don't have much information about it. What about studies that compare psychosocial and pharmacological treatments? You look at the MTA study, which is a very big study. One of the things to keep in mind here is that parents prefer treatments that include behavioral components. So this looks at people who got medication management, combined treatment, or behavioral treatment in the MTA study. And if you add the top two lines, you see that 20% of people who got medication management either dropped out of treatment or wouldn't recommend it. Well, for behavioral treatment, that was only 5%, much less than that. Strongly recommending it is 38% versus 67%. So parents like the psychosocial approaches. They like learning skills, and teachers like learning skills. I was going to show you a couple of slides about studies that we've done recently. Our research group does lots of studies, and let me skip ahead several slides because I know I had a lot of slides in here, and just show you this slide. So we did a big study where we had children attending a summer camp program, and in the summer camp program we either treated them with a very high intensity of behavior modification, just about everything that you can think of that you would do with children, with ADHD children, to provide really intensive treatments. We also had no behavior modification, and that meant they were in our summer camp, but we didn't use any behavioral treatments to control their behavior. That was very hard for the staff to do, not surprisingly. And then we had something in between. And we crossed those types of behavioral treatments with different doses of medication, all the way from a very low dose, 0.15 milligrams per kilogram of methylphenidate, that's what we used. That's Ritalin or Concerta or Metadate for those of you who don't know the generic name, to a high dose of 0.6 milligrams per kilogram, and that was dosed 3 times a day. And this slide just gives you a sense of what we found. The blue line is children who were not getting any behavior modification and only medication. So on the far left, it shows you that those children had 60 rule violations in 30 minutes in their classroom setting when they had no behavior modification and no medication. And then they went down to about 20 rule violations with a high dose of medication. If you had a low dose of behavior modification, they were better. They went down to about 15 rule violations. A high dose of behavior modification, they were even better, down to about 8 rule violations. The most important thing here is that if you use behavioral interventions, there are relatively few incremental benefits of medication. So this shows the importance of providing behavioral, because then you can get away with much lower doses of medication. Look at the difference between the effect of the 0.15 milligram per kilogram dose in the no behavior modification compared to either of the behavior modification conditions. It's a huge effect, and you don't get much more if you double the dose or double it again. So that shows you the importance of doing psychosocial or behavioral treatment. I'm going to skip this slide. And this next slide just essentially says, it was following up the children in that study. And it says that if you try doing behavioral treatments with a family and you check with it, you do good, a daily report card in school, and that's all, just a daily report card like the one I showed you set up with teachers, that you ask teachers how the child's doing. And if the child's ever doing badly, then you prescribe medication. What you can see from the left-hand panel here is that the people in green were far less likely to get medication. Those people got simply a daily report card at school. And the vast majority of the children who just got a daily report card survived the entire school year without needing medication. So what one finds in an intensive summer program, you can also find in school settings. And the last thing I want to show is the latest study we've done, which is a very big impact study that's under review right now. We expect it to change the way ADHD children are treated. And that's one in which we looked at whether it's better to start treatment with behavioral treatment or to start treatment with medication. If children didn't do well, then we either gave them more of what they started with or we added the other modality in. So we either gave them more medication at a higher dose, or we gave them more intensive behavioral interventions, more doses of behavioral treatments, or we added the other modality in. And the results showed pretty clearly that if you started treatment with behavior modification, and the behavior modification was some parent training and a daily report card, that's it. 8 sessions of group parent training and a daily report card. Then the kids were far better on almost all the measures at the end of the study, at the end of the school year. So starting treatment with behavior modification was better than starting treatment with medication, even if kids needed more treatment. What do we think the difference was? Well, it turns out that if children were started with medication, even if later they were evaluated by their parents and teachers as needing more treatment, parents who were assigned to come to parent training never came to parent training. At the beginning of the study, if they'd been assigned to parent training to start, they all came to parent training. But once they had medication, then they didn't follow up with the recommendation to come to parent training. That's why we think that this study showed that starting with behavioral treatments before medication is so important, because medication first undermines the parent's commitment to get involved in parent training and to set up a daily report card with the teacher. I think I'll skip that one. So finally, our recommendations for evidence-based treatment of ADHD. If you've been listening carefully, you already know what they are. It's to focus on impairment in daily life functioning instead of DSM symptoms. Depending on the child's severity, start with behavioral intervention, behavior management with the parents, teachers, and children, and evidence-based academic interventions if necessary for a child who's falling behind academically. And add time-limited medication when your problems in daily life functioning are not dealt with behavior management alone, and parents prefer medication. And when you're using medication, you use low doses, not high doses, so as not to remove the need for behavioral treatments and to minimize side effects and risks. And then the second point here is that you make interventions feasible and palatable for families. Families are going to have to continue working with their ADHD child all the way until their ADHD child is an adult. And their parents, I'm sure, who have adult ADHD children, and they can tell you that they still have to work with their ADHD kids. They still have to do things to help their kids as young adults. So this is a lifelong process, and it involves parents making a commitment and sticking with it for a very long time. And the last point is schools and doctors and parents have to work together to provide effective treatment for kids with ADHD. And Here are materials that are available on our website at Florida International University, and one of the things here you'll see is how to establish a school-based daily report card. So I encourage you to go to this website, ccf.fiu.edu. You'll find lots of information that's useful about children with ADHD. It's a great source. ccf, Cat Frank, ccf.fiu.edu. Thank you very much for listening, and I look forward to questions.
Thank you, Dr. Pelham. I think this has been a wonderful overview. To our audience, we are ready to start taking questions, and I know a few questions have already come in. You can enter questions on the control bar to your left on your screen. And our first question comes from Kevin. And he was wondering, what is the difference between psychosocial and cognitive behavior therapy and traditional counseling or counseling in general?
That's a good question. So the general approach with with behavior therapies. See, cognitive behavior therapy is not what I've been talking about here. Cognitive behavior therapy is the main approach used with adults with almost any kind of mental health problem. And that involves working with the adults to teach them adaptive ways of thinking differently and of behaving differently. Cognitive behavior therapy, teaching the children new ways of thinking, doesn't work very well. For the children, we need to teach parents how to manage the kids' behavior and teach teachers how to do that. And it's the parents and teachers' changes in their practices that will get the child to change. As a child moves into adolescence and adulthood, then the intervention becomes more cognitive behavioral, meaning that you involve the individual more in discussions of what their problems are and how they need to change their thinking and their behavior to improve. Traditional counseling, what traditional counseling looks like is you take your child to a therapist, you give them to the doctor, therapist goes inside the room with the child and they play together for an hour. That's play therapy. That's traditional counseling. There's no evidence that that has any beneficial impact on a child with ADHD. Parent could pay for that, pay $100 an hour for 52 weeks a year for 10 years, and it would have no benefit for the child. So what you want to know is go to our website and look at the material called Psychosocial Treatments for ADHD. And that's a 10 or 15 page packet for parents that describes what parents should be looking for. Or you can go to our website called effectivechildtherapy.fiu.edu, and that Effective Child Therapy website actually has tons of videos, not only about treatment for ADHD, but about lots of other things for parents and professionals. And those go over the differences between effective psychosocial approaches to treatment and useless psychosocial approaches to treatment. Thank you for the question.
Thank you for the answer. Well, our next question follows that up, and it's from Stephanie. And she was wondering, is coaching considered a form of behavioral modification? A lot of times at the National Resource Center on ADHD, we'll talk about academic coaches for children who are in high school and for young adults. But Stephanie was wondering, is this a form of behavior modification?
Yes. If what a coach is doing is helping the teenager, for example, adopt skills like organizational skills and good time scheduling skills for when they should study and when they should plan ahead to do homework and so forth. If a coach is helping them do that, then that coach is essentially functioning as a behavior therapist for the child. We have a summer camp that Dr. Margaret Sibley here has developed for teenagers. It's a summer prep program where the ADHD teens come to our summer camp every day for 9 hours for 8 weeks in the summer, and they learn all the skills that would help them function when they go back to school. And they're all skills on organizational practice, how to study, how to get along with other teens, how to get along better with the teachers in the high school setting, and so forth. And all the staff that we use are essentially coaches. They're coaching the kids to learn appropriate skills. So coaching can be a very effective way of delivering effective psychosocial treatments for ADHD. In fact, in our summer camp for younger kids, a lot of what the kids focus on during the summer is sports activities. And in the context of the sports activities, we're teaching them better social skills with other children. And when we do that, our counselors are working essentially like coaches for children's Little League and children's basketball and children's soccer. So that's a good question. Coaching is good.
Thank you. Coaching is good, and the summer camp programs are very helpful. The summer treatment programs, we've heard wonderful things. Well, our next question comes from Kim, and she was wondering, can you give her some specific examples of psychosocial and behavior modification approaches to addressing ADHD behavior? Her big question is, how can she know if she's doing this right? Well, again, I'd suggest going to our website and downloading that one packet for parents on psychosocial, effective psychosocial approaches for children. And actually, that handout on our website is the same as the handout on the CHAD website on psychosocial treatments for children with ADHD. I wrote it for CHAD way back when I was in their professional advisory committee. So at either the CHAD website or our website, you can get that and just read it, and it will tell you what the specifics are. There's lots of information. It tells you exactly what you should look for when you're seeing a therapist. If you go to our Effective Child Therapy website, I give a talk for parents that tells them how to recognize what good psychosocial treatments are. So basically, when you're going to a therapist as the parent, and you wonder whether you're learning a good psychosocial treatment, are they teaching you skills that you can then take home and implement with the child? Or are they sitting there and letting you talk about your own concerns and your own problems, making you feel better, but not teaching you skills? The skills teaching part is really important. Well, expanding a bit on skills teaching, we are getting questions from several parents, and they're wondering if you could expand upon the daily report card concept, upon the daily report card that you've developed. And generally they're wondering if a child does poorly at school, getting a lot of no's, a lot of correction, and then gets punished at home for something that is the result of a disability stemming from ADHD or a co-occurring condition. This sounds kind of rough for these children. If the teacher is unsure how to set up the child for success, how can a report card help generate the success? How does this daily report card work to help this child? Well, of course, the parent who asked that question is correct. If you're giving a child a piece of paper to take home to his parent every day that says, "I had a terrible day at school," that's not going to help anybody. So you work with the teacher to figure out what the main goals are that the teacher wants the child to reach in school. What are his main problems, and what are the goals that he has to reach to show improvement in those problems? And you always start low. So you start at where the child's currently functioning and set as a goal for him to function a little bit better. And you might do that for 4 or 5 different goals. And you make it easy enough that he's going to be successful 3/4 to 80% of the time. So most of the time, the child has a successful day. And then as he gets better and better at having successful days, the teacher should increase the difficulty of the goal just a little bit. So if the initial goal, if a child is finishing none of his seat work at school, then our initial goal might be finishes 10% of his seat work. And if he gets 10%, that's great. He gets a yes on his daily report card. And if he does that for a week, then raise it to 15%. If he does that for a week, raise it to 25%. It may take you 6 weeks to get to the level that you want, but you've done it through success. And that success is important to motivate the child, keep the parents motivated, and to make the teacher committed to doing the daily report card. And again, go to our website and download the packet called How to Establish a Daily Report Card for Your Child with ADHD. Most pediatricians who have the ADHD toolkit also have a copy of our daily report card procedure. We modified it for the American Academy of Pediatrics, and they passed it out in their ADHD toolkit. In fact, I think Chad has one too. Chad has our wonderful program, Parent to Parent, and for our audience members who are interested, you can find more information on the Chad website, which is chadd.org, and we have information there along with where and when upcoming parent-to-parent programs are being offered across the country and also online. Well, we have a question now from a parent who is wondering how many professionals generally have adequate training in psychosocial treatment. Our parent says there seems to be a shortage of knowledgeable doctors and therapists in this area, and is that a misperception? Are there more than there seem to be?
I think that there, in school settings now, there are probably a lot more than there seem to be. In the last decade, schools have done a much better job in America with teachers learning about how they need to be working with ADHD children in the classroom. Teachers may not always do it, but most of them have been taught how to do it. And so a parent's goal is to get a fact sheet on a daily report card and then go to school and meet with their teacher and say, I'd like you to do this with my child. If a teacher says no, then a parent should find out what the procedures are in their school district to request a 504 plan. And in the 504 plan, which is a federal requirement to provide services for a child with a disability, the parent wants to get that approved from the school and to require in the 504 plan that the teacher do a daily report card. And then the teacher has to do a daily report card. When they start doing it, they'll find that it's very helpful. It's not that hard to do. If the 504 plan is not enough, then a parent can request an IEP for a child with ADHD and go through the school district procedures to do that. But almost every teacher in America knows how to do good classroom management practices. Sometimes they need to work closely with the parent to get it started. And people as parents need to understand that a teacher has got, 25 other kids in the class in addition to your child with ADHD, and what parents need to do is to help motivate the teacher to help their child. So I tell them try to avoid fighting with the teacher. Try instead to motivate the teacher. If you're doing a daily report card and the child's had a good week, at the end of the week, take a piece of pie into the teacher on Friday afternoon, for example, and tell them thank you for having worked with your child that week. So do things to reward teachers for the efforts that they're putting in with your children.
Thank you. I think one of the things that we have said many times at the National Resource Center on ADHD, when you go in to talk with teachers, a little bit of honey goes a long way. We have actually heard of one parent who used to bake cookies to bring into those meetings. Well, our next question is actually going to be...
That's a great point. Actually, we bake cookies for teachers when we're doing our studies for exactly the same purpose.
Well, cookies are a great healing agent in this world. I'm very fond of cookies. Well, our next question is two questions together, and the questions are coming from Wendy and from Katie. And the questions really, they go together. The first one is, will psychosocial skills and treatment stick without medication for children who have moderate to severe ADHD? So will these treatments, the behavior management, behavior modification, work for children who are not using medication? And Wendy follows that up with, is behavior management effective for children who have oppositional defiance or conduct disorders?
Those are good questions. The answer is yes, the treatments stick. Actually, there's as much evidence that good parent training and daily report cards and good classroom interventions and good intensive summer programs work for children with ODD, oppositional defiant disorder, and for conduct disorder, as there is that they work for ADHD. And just as long a history. So for 40 years, we've been using these approaches with kids with ADHD, conduct disorder, ODD, the combination, Asperger's, and they work for all of these kinds of problems in children. And it works with or without medication. The one limitation, the one thing I would say is that if you use a little bit of medication, you can get away with using a less intensive approach to behavior modification. So for a typical ADHD child who gets a daily report card, you might need to add something to that in the classroom to have that be sufficient. However, if you give a little bit of medication plus a daily report card may be sufficient for a child with ADHD. So one of the big advantages of combining the two approaches is you can use a little less intensive aspect of each one. So you can use lower doses of medication, which have fewer side effects, and you can use a less intensive psychosocial treatment, which means not as many sessions, so it's not as costly, not as hard for a teacher to do in school or for parents to do at home.
Thank you. Well, we've got a question now from Joyce, and she has a 9-year-old grandson that she's raising who has ADHD, and her grandson is withdrawn at school. She says the medication he's taking seems to be helping, but at home he can be impulsive and aggressive. And what Joyce was wondering is, what's the best way to help curb some of that aggression?
It would be to go get some behavioral parent training. So find out from your local community mental health center or from your child's school where you can get involved in a group behavioral parent training course and learn how to work with that aggression at home. It's the same techniques that I had on the slide earlier, so you can go back and look at the slides. The slides are posted. The one on parent training tells what the techniques are that you use, and use exactly the same techniques for a child who's aggressive as you do with ADHD. In the example you just gave, you said the child is somewhat withdrawn at school and he's impulsive and aggressive at home. It's pretty unusual for a child to be withdrawn at school and then impulsive and aggressive at home unless he's medicated a lot and perhaps over-medicated. So if you have a child who's withdrawn behavior is one of the side effects of high doses of medication. What I look for, and when we medicate children, is kids that are not withdrawn, and they're not perfect, but they're better than they were before because we're using low to moderate doses of medication. So that parent might want to check and make sure that the withdrawn behavior at school is not a side effect of medication. Thank you for the question.
Thank you for the answer. I think that was an answer that not just Joyce, but a lot of parents and grandparents raising children do have, and it is a concern that we have heard at the National Resource Center on ADHD. You mentioned, again, parent training, and we have a question from a couple parents who are wondering, are there any specific evidence-based parenting programs that are widely available? In addition to the summer treatment programs, which I know, again, began at the University at Buffalo, and you also continue at Florida International University, are there some other programs or similar types of programs that parents should be looking for parent training?
Yeah, there are a dozen scientifically evidence-based parent training programs. And again, if you go to either the CHAD website or our website, it lists a bunch of those. And it also tells you what the components of them are. So you know what to look for in your own location as far as a parent training group goes. And again, rather than going through the list of 12 to 15 of those, just go get the downloadable information from our website or from the National Resource Center website or the CHAD website, and you can look for that. One of the most common ones that's around the country is called Triple P, Positive Parenting. That's a very good program. Another one is PCIT, Parent-Child Interaction Therapy. Another one is Strengthening Families. So there are a half dozen of them that are really good, and you just have to look in your community and look for effective parent training programs. And as far as the summer programs go, there are many fewer places in the country that are doing summer programs like ours. There are lots of people doing short-term summer programs for ADHD who've taken bits and pieces of the evidence-based programs. Ours is offered in about 10 or 15 cities around the country, including Miami, Cleveland, New York City, Boston, Kansas City, Chicago, Seattle, Salt Lake City, and so forth. And they're all variations of this summer program that we've been doing for 30 years. And you can learn about that also from our website. We list all the different places where people are doing summer programs for children with ADHD.
And again, I've got the website posted so that our audience can jot that down, and also the PDF that you can download from this webcast also has the link on it. Well, our next question is coming from Jim, and he was wondering, are positive discipline parenting techniques helpful and effective for kids with ADHD? So techniques that can be referred to as positive discipline. Are they useful?
I'm not sure what positive discipline means. If it means discipline without physical punishment, then yes, that's the preferred approach to discipline. And if it means trying to reward the absence of behavior, that's what a lot of people might refer to as positive discipline. rewarding the absence of bad behavior is a good approach to working with children, because you're encouraging them to be good and not necessarily providing punishment for their being bad. So positive approaches to discipline are something important that one learns in good behavior management and parent training programs.
Thank you. We've got a question now from Mick, and he has an older child, and he was wondering, does behavior modification work with older children? Rather than, at this point he has an older child, so would it work for the older child beginning now? And I believe this child is in middle school. Or is this something that we have to begin solely with younger children and we're kind of stuck when it comes to the older children?
Oh no, you do behavioral interventions starting at any age. They are probably most effective when you start them at a very young age and continue them throughout childhood, but it's never too late to start. In fact, lots of parents have children with ADHD, for example, who are very smart. And if a child is very smart and he's not aggressive, he may go all the way through elementary school without having major problems. And the reason for that is elementary school teachers often go out of their way to help children like that who need extra help. And they work with the parents to do it. And then the child hits middle school. Middle school teachers typically do not go out of their way to help people. They expect much more from the children. And that's a point where parents can step in and get involved with the therapist or get involved with the school and start working on the child's functioning in the school setting. As I mentioned earlier, in our summer camp programs, we have programs for middle school kids and middle school parents. We also have this in our outpatient clinic where we teach the parents how to work with the children on improving their academic functioning in school and improving their study skills in school. And that involves working with the parents and the children together, teaching them ways of negotiating good homework strategies and things that are helping both the parents working with the child and the teen's perspective working with the parents. So it's never too late to start. There are effective things to do at every age of children, all the way to college.
Well, we have come to our last question, Doctor, and this one kind of wraps us up a little bit. You've talked about parent training, and this one actually now refers a bit to schools and working in the classroom. And we have a parent, Rob, who says that for social skills, they have been asking the IEP team to pair their child with another child as a role model to help him improve his social skills. But the response from the education team has been to do play therapy at home, that they're not going to pair their child with another student. So Rob is wondering, how can they persuade the school to help? How can they persuade the school to start using some of these techniques that you've discussed and perhaps help them have their child paired with another student as a role model, as an assistant? How does a parent prompt the school to move forward on some of these things that you've discussed?
So the question actually says, the one that I'm looking at says, the school IEP team is not ready to pair the child and so forth. That would presume that the parent who's asking, that their child has an IEP. If they have an IEP, then what they need to do is to ask for a formal meeting and for a modification of the IEP, and the parents need to write into the IEP having a peer helper, a peer role model in the classroom setting. The great thing about having an IEP is it's a legal document, and the parent can insist, if they get something in the IEP, then the school has to do it. They can insist that the school does it. The limitation of the school may be that they may say, we can't force another child to do this with your child. And that's true. But they can ask other parents if they're willing to let their child be a helper to an ADHD child in the classroom, and they can ask the other kids if they're interested and willing to do that. So it shouldn't be automatically ruled out. At the same time, the parents should be working on this in the home setting. They should be having play dates at home, for example. And they should tell the school that they're doing their part. Now they expect the school to do their part.
All right. Well, Dr. Pelham, I want to thank you for your time with us today. Behavior management is an important part of treatment for ADHD, but it is often misunderstood or misapplied. And I think you've explained this approach. And those who are listening to the recording have a better, and those of you who are listening to the recording You will also have a better understanding of behavior management and how to incorporate it into your child's treatment plan. Thank you very much for your time, and I think this has been very helpful for our participants.
Thank you for inviting me, and thanks for hosting, Karen.
Oh, we're so pleased to have you, and we're very glad to have been able to host you. For our participants, we'd like to share with you that we have a special event coming up where we have a special broadcast. On Wednesday, December 3rd, we will interview Megan Murphy, and she is a consultant with LECO Tech and a developmental therapist. Some of you may be familiar with LECO Tech as they help Toys R Us put together their toys for differently abled children. And Ms. Murphy is going to talk about picking out gifts and toys for children affected by ADHD and other cognitive disorders. And this is a podcast that can also be downloaded for listening. You can register starting tomorrow afternoon at helpforadhd.org and also on the CHAD website at chad.org, Ask the Expert. Dr. Pelham, I'd like to thank you again for being with us, and I'd like to thank our audience. I hope you all enjoy the rest of your day. Thank you very much, and this concludes our presentation.
Thank you, Karen.
Thank you.